Thank you so much for having me again. It's great to see a lot of the faces that I've met before and also to meet a lot of new folks here. So this is really, really an honor for me. And to just talk a little bit more about how much I enjoy this and what motivates me to keep working with all of you is that this is just one moment where I'm giving this talk. But afterwards, I usually get a lot of emails and I like them and I encourage you to reach out to me. And through these emails, we can find ways, because I'm not your kid's doctor, like we heard earlier, I can help you find care locally and sometimes even abroad that can get kids treatment that they need just by me maybe sending an email. And I'm happy to do that. So please use me as a resource. I'm happy to help. So sort of focusing in on the eyes in CTNNB1, this is a figure from Spella's paper from a few years ago, and you've seen it, and even a newer one from Wendy earlier. But we know that many of the kids with CTNNB1 have eye abnormalities, and whether they're severe or not, and whether they lead to vision loss or not, sort of depends on what they are, when they happen, and whether or not they're treated. We don't know. Also, like Wendy pointed out, everything about what happens with time, so progression over time, we're not exactly sure because we don't have that many old CTNNB1 patients. And we also don't have the genotype-phenotype correlation nailed down, which I'll mention again later. So what are the eye manifestations of CTNNB1? So by and large, the most common is strabismus. And if you look at the top right of my slide there, then what you'll see is that there is a picture of a kid with their eyes crossing in, which is esotropia, and a kid with their eyes crossing out, which is exotropia. They can also be misaligned vertically or in different patterns that vary with time, and we describe them based on what we see. But this is importantly not a cosmetic problem, although it has implications for that too. This is either a reflection of the fact that the eyes aren't working well together and so they can't stay straight, or a reflection of the fact that one eye doesn't see, and so it's kind of doing its own thing and not able to be brought in. And so that needs to be evaluated by an ophthalmologist for those reasons. And if it's simply just that the eyes aren't working well together, sometimes doing a surgery to straighten them will make them work together, and that will improve the vision for that child for the rest of their life. So it's something that has to be fully fleshed out. So I have a figure here from a paper that just points out that a lot of these kids, if you take a picture of a bunch of kids with CTNNB1, and it's true for many of the children that I've met, strabismus is very, very common, and having it evaluated is important. There's also one more common thing in CTNNB1, which is a need for glasses. And so having either nearsightedness, farsightedness, or astigmatism is very common in CTNNB1. And it's not a small problem. If we don't give kids when they're young a sharp image to focus on their retinas, then they won't fully develop their vision. And kids with CTNNB1, like many other neurodevelopmental disorders, aren't going to tell us that they don't see well, right? So we have to look for it and evaluate for it, get them glasses and get them seeing well to develop their vision in their brain to the maximal extent. But really what we are talking about when we're talking about eye involvement in CTNNB1 often is fever. And so in the paper here, we've found about 23, well not we, but Spella found about 23% incidence of fever, and I'll talk a little bit more about what we think about that now. So spending a moment or two about what is fever, I want to just show a couple pictures of a normal retina. So this is a normal child's retina that has blood vessels, arteries, and veins, and it has an optic nerve where the arteries and veins come in and out of the eye. And we can study the blood vessels even better in normal patients or patients with different retinal disorders, or especially with CTNNB1, by doing something called a fluorescein angiogram, where we either inject a dye in a vein or have them drink a dye, and that really highlights the blood vessels. And I'm showing you this picture because fever is primarily a retinal vascular disease, and so we want the best possible contrast of the retinal vessels to understand what's going on. So now moving on to pictures of patients with fever, we talk about fever in terms of stages. So we have stage 1, 2, 3, 4, and 5. Now, stage 1 highlights kind of the earliest version of the problem with fever, which occurs in CTNNB1 patients, of course, which is where the vessels didn't finish growing, so they stopped too early. And that can be a static problem, meaning the patient doesn't have quite enough blood vessels and they stay like that their whole life, or it can progress to stage 2, where new blood vessels grow at the border of normal and abnormal, and then those blood vessels can bleed, or they can detach the retina, which is then called stage 3. Stage 4 and stage 5 can be the result of a patient going from stage 1 to 2 to 3 and then to 4 to 5, or, like I'll talk about in a moment, a child can actually be born with stage 4 or stage 5 fever, and they never really went through that normal cascade of stages because of the problem being more prominent in utero. So both can happen. But really the crux of my talk here is that if we can identify kids who are at stage 1 or stage 2 and can receive treatment so that they don't go down the pathway to 3, 4, and 5, then that's really the goal of early identification and intervention. So what causes fever? This is basically the same slide that Kellen showed you guys, and I'm showing it for a different reason. So if you take a step back, and I see a lot of kids with fever in addition to CTNNB1 patients, and they have these genes that are listed here, LRP5, Frizzled4, TSPAN12, and NDP. Those are all critically involved in the Wnt signaling pathway. But what's most interesting to me is that beta-catenin, which of course is relevant for everyone in this room who has a child with CTNNB1, is the downstream signaling molecule of all of those genes. So it's actually more surprising to me that not all kids with CTNNB1 have fever, meaning there's a plausibility that every single one could, and we know that that's not true. But it's immensely biologically plausible that we see fever in CTNNB1, which is why we have to look for it in everyone. Within fever itself, we identify a genetic cause about 50% of the time, and we think that, at least right now, CTNNB1 is only a minority of the fever cases that we see. The other genetic variants are much more common. So all of these Wnt signaling mechanisms, why they cause fever is because it's a problem with developing blood vessels, angiogenesis and vasculogenesis, which then leads to the downstream consequences of pulling on the retina, holes in the retina, retinal detachment, and so on. So when we were first learning about CTNNB1 from an eye perspective, we saw kids who would present with retinal detachments at birth, like I mentioned. And so we thought that CTNNB1 related fever would always be very severe. So a lot of case reports came out with a lot of stage 4 and stage 5 fever cases. And those definitely do exist. And they usually manifest by a child either having a crossed eye at birth, or nystagmus, or the eye is moving like this, or the eye is smaller, or there's some characteristic appearance of the eye. And those are usually kids who get diagnosed with CTNNB1 when they're very young, like 6 months or younger, because they have fever. But there are a lot of kids who have CTNNB1 who we didn't know had fever. And we thought this was true, but then we did a study at CHOP to prove this, which I hope has been very helpful for the community in general. So we took kids who had been seen in the office usually many times, 82% of which had strabismus, 55% of which had previous strabismus surgery, who were not diagnosed with fever, and we looked very closely to see if we sedate them and do a fluorescein angiogram, will we find fever? And this was very important and helpful for the kids in this who were studied, because we found that fever was very common, and it was typically low stage. So 46% of the patients and 38% of the eyes had fever of any stage, and 27% of the eyes required treatment. And these are kids we did not even know had a problem until we looked. And there was even one retinal detachment in this cohort. And this is sort of what was really powerful to me to push anyone who emails me like, hey, can you send a letter to my ophthalmologist because they won't do a fluorescein? Yes, absolutely I will, because I know that these kids are going to have disease that can be missed. My cohort has grown, and I have a caveat here, because you see my incidence has gone up to 63%. But this has now, for me at least, become kind of an enriched group of patients, because people are sending patients to me for fever, not specifically just for CTNNB1. So I'm seeing more patients with CTNNB1 and fever. So I don't think you can conclude that the incidence of fever is going to be 60% in the general population of CTNNB1. But suffice to say that a lot of kids require treatment when they have CTNNB1 for fever. We've tried preliminarily to do a little bit of genotype phenotype. Oh, that didn't really show too well. We've tried to do a little bit of genotype-phenotype correlation work in our cohort, but we haven't really found any obvious signs of who has fever based on where their variant is on the gene. But stay tuned for that. Now, I've shown this work of mine before, but I just wanted to point out that another study came out pretty recently from a group in Utah, and actually there are a couple people from Utah here, which is basically echoing what I just told you about. So I'm going to read the quote from their paper. Patients in our cohort require treatment for fever despite repeatedly normal dilated examinations in clinic over multiple years. So just having a normal exam in clinic is not sufficient to diagnose fever. I'll just draw your attention to this box in this very busy table, but if you look here at my little rectangles, there is a category that says fever diagnosed by clinical examination minus, and then fever diagnosed by wide-angle fluorescein positive. And then below that it says treatment for fever. So 3 out of the 4 patients who had fever that were missed by clinical exam ended up receiving treatment, which is very important and hopefully prevented them from having vision loss down the line. They also, at the end of their paper, have sort of a big analysis of published fever cases, so 136 patients, and of that group, about 37 had fever, and 70% of those had stage 3 or higher. So I think that in the literature, like I alluded to before, there's an overrepresentation of advanced stage fever, but still having a large percentage of patients with fever in known cases of CTNNB1 is relevant and important for considering our management strategies with time. So just to wrap up here, for screening for CTNNB1 patients, it's really important, and I personally would advocate to have kind of a team-based approach. So all CTNNB1 patients should have a pediatric ophthalmologist, and they're, just like for me, my main go-to for having patients management for strabismus, for glasses, for a lazy eye, and sometimes rarely cataract or glaucoma, which can happen in CTNNB1. And then usually, but not always, there's going to be a separate person, like a pediatric retina specialist like me, who would be the one who's doing the screening for fever, okay? And earlier is better. If you can combine it with another anesthesia event, like for MRI, or for strabismus surgery, or for anything else, then that's great. Minimize the anesthesia burden on the child if possible, but this is still important. And then in terms of treatment, same sort of thing, glasses, strabismus surgery, patching if needed, cataract surgery, et cetera, anything that's needed to maximize visual development. And then also for fever specifically, if it's mild, it can be observed, or we're talking about laser or retinal detachment surgery. And then my last slide here, I promise. This is a complex multi-system disorder, which often involves the eyes. I don't have absolute data on incidence of fever. My gut instinct based on my experience and what publishes is probably about 40%, but probably only about half of that needs treatment. So maybe about 20% of kids or less have fever that needs something done, but that ultimately will come out in the data from Wendy and others about collecting more and more data from patients at a granular level. Vision in CTNNB1 we think overall is good, but there are obviously exceptions. Severe stage fever is often vision limiting, or sometimes we see kids with neurodevelopmental disorder who have healthy eyes, but the connection between the eye and the brain doesn't allow the vision to be as functional as we expect. And so it's hard to just know right off the bat doing an eye exam whether the kid can see well or not. And then in terms of what we're going to do next is, I'm like I said, would hope to be a resource to the community and continue to sort of accumulate knowledge about CTNNB1 and what we see and what we need to do with time. So thank you all very much.